Okay, thank you, everybody. So good morning, good afternoon, good evening all. Bonjour et bienvenue. So a very warm welcome on behalf of the IAPB events team to today's World Health Assembly side meeting, Universal Health Coverage and Icare, Promoting Country Action. And it's really wonderful to welcome both in-person and virtual attendees to today's meeting. So we're just going to open with some short housekeeping notes before handing over to Jennifer Gersbeck, the Executive Director, Global Advocacy for the Fred Hollows Foundation. So first of all, we're delighted to offer international sign interpretation throughout. And we also have closed captioning in English for today's session. So that's for both our virtual and in-person attendees. So anybody in the room who would like to look at the English closed captions, we recommend that you link onto it through a portable device such as your mobile, and you type the following link into the browser. Now, we're going to keep it up throughout, so it's just on there. It only takes a couple of seconds, and you'll be able to watch the captions. And for our virtual attendees, you'll be able to download a desktop app called Streamcast to overlay the captions, and you'll be able to see it at the same time as the screen of what you're viewing today. And again, we're going to post some detailed instructions for you in the hop-in chat, but it, again, should only take a couple of seconds to set up. Just to let you know that there might be a few seconds delay. We have engaged live captioners for accuracy, and our sign interpreters are following the captions as well. And a big thank you to our captioners and sign interpreters for your help today. Okay, so fire exits, just probably the way you came in, so just turn left and right down the stairs onto the street. Please be aware that, let me just realised. I'm in charge of the slides, so apologies. Please be aware this webinar is being recorded and will be available to watch and share via the IAPB website and YouTube channel post-event. We'd like to encourage you to use social media channels to promote and engage a wide audience with this event. So please use the following hashtags. So we've got WHA75 and 2030 Insight. And of course, we'd like to engage everybody in the meeting. So we'd like to encourage our virtual attendees to post comments and questions using the chat feature on Hopin. And please just, for our in-person attendees, you'll be invited to ask questions verbally later on. And finally, for our virtual attendees, if you're experiencing technical difficulties, please contact us using the chat facility on Hopin or email events@iapb.org. Okay, so thank you very much. I'm now delighted to hand over to Jennifer to welcome you to the meeting.
Thanks, Deb. Ministers, Excellencies, government delegates, friends, welcome to this hybrid event in the sidelines of the 75th World Health Assembly on Universal Health Coverage and Icare, Promoting Country Action. What a pleasure it is for me to be here today in person in Geneva at the Fairmont Hotel with some of you. And in putting good use our learning over the past 2 years of communicating while apart, it's also my pleasure to bring those of you joining virtually from around the world into the room. Welcome, everyone. As Deb said, my name is Jennifer Gersbeck and I'm the Executive Director of the Fred Hollows Foundation. I'm also a member of the Board of Trustees of the International Agency for the Prevention of Blindness. And allow me to also acknowledge our co-hosts, the World Health Organization, CBM, Light for the World, and Sight Savers International. We stand here today conscious that we are still living through the devastating effects of the COVID-19 pandemic, mindful of the millions of lives lost and touched, the winding back of the clock on many areas of progress, and the significant challenges still ahead. Yet hopeful that we will grasp the opportunity before us to rebuild forward better, realign public health as a foundational pillar for social and economic development, and that we will reimagine what is possible in achieving universal health coverage for all. Today's event is in recognition of the global public health challenge of blindness and vision impairment, a challenge that sees more than 2.2 billion people living with a vision impairment around the world, over 1 billion of whom with a condition that can be treated or could have been prevented. a challenge where we have cost-effective solutions to hand right now to address 9 out of every 10 cases, and a challenge that without urgent attention will find the number of people living with severe vision loss triple by 2050. In 2020, during the session of the 73rd World Health Assembly, leaders committed to turning the corner, to making eye health part of efforts to achieve universal health coverage, and to implementing, I should say, definitely not eliminating, integrated people-centred eye care. Whoops. Across the spectrum of all health services. Returning in 2021, the 74th Assembly adopted ambitious new global eye health targets on cataracts and refractive error to be achieved by 2030. And during the 75th session of the United Nations General Assembly in New York, leaders passed the resolution on vision for everyone, recognising eye health as an accelerator to achieving the Sustainable Development Goals. These are great achievements, and we acknowledge the leadership, particularly of Antigua and Barbuda, Australia, Bangladesh, Indonesia, and Ireland in steering us through. And today marks the next vital step with the launch of the World Health Organisation's Icare in Health Systems Guide for Action, a comprehensive guide to assist countries through the process of implementing integrated people-centred eye care. Our co-hosts from the WHO will take us through a briefing on the guide, and we will hear from leaders turning their attention to implementing the approach at the country level. But first, we are fortunate to have a number of distinguished keynote speakers to set the scene for the conversation. And so firstly, may I call upon Dr. Lokman Hossain Mia, Senior Secretary, Ministry of Health and Family Welfare, People's Republic of Bangladesh. Mr. Secretary, you have the floor.
Thank you, moderator. Assalamu alaikum. Very good morning, very afternoon. Distinguished panelists and participant excellencies, ladies and gentlemen, good morning. It's indeed my honor to speak on universal health coverage and eye care. At the outset, I thank the international agencies for the prevention of blindness for organizing this event. We know that eye care is related to SDG Target 3 on the health and well-being, as well as SDG Target 3.8 on universal health coverage and eye care. In the greater landscape of universal health coverage, eye care services have the potential to advance universal health coverage. Now, prior to shedding light on the perspective, I would like to share our experience in improving eye care services to our people. Among the most common eye diseases in Bangladesh that affect a large number of our population are cataract and visual impairment or low vision. Among these, untreated cataracts is widely prevented and causes the blindness to the people. It is noticeable that in our country, the prevention of the blindness among 30 years and above age group is 1%. This is reduction to the level of the 2000 by 35%. Around 14.3 million people in the same age group are also suffering from the visual impairment of low vision. Because of the domains of cataract in causing the blindness, we have put priority on its treatment and surgery. Both government and private hospitals play a vital role in facilitating cataract surgery. We have undertaken various programs to facilitate cataract surgery free of cost in government hospitals. And charitable organizations also provided eye care services and facilitated cataract surgery at a minimal cost of the financially challenged segment of the society. We have incorporated Icare in primary healthcare services. This helps us reach the people at their homestead and reduce the pressure on the secondary and tertiary level hospital also. As a component of public health services, we aim at ensuring a continuum of health intervention on the eye health treatment, particularly promotion, prevention, treatment, and rehabilitation. We have been running health insurance scheme for the last 5 years as a pilot program that incorporate eye health services as well. Among other initiatives, 135 community vision centers at primary level serve the people at the root level. They also provided telemedicine services. We hope this pilot program will be a successful case and open at the avenue for the further extension. We have put emphasis on the training of the eye health workforce, including the nurses and microsurgery and both sub-specialists also. This apart, we have arranged eye care training for primary health workforce. We are keeping medical record of the patient electronically and monitoring them regularly to improve our efficiency in service and delivery. Over a decade, we have been running vitamin A plus campaign 2 times a year to prevent night blindness of the children. This covered almost 100% of the children also. Now I'd like to put my perspective to ensure eye health service for all such as follows. First of all, to launch the social campaign, awareness building through the print and electronic media. Second, to generate global support to emphasize the importance of the eye health services universal health coverage. Third, to encourage government to allocate additional funding to support low-cost eye health services to the vulnerable segment of the society. And finally, to enhance whose support at country level to encourage the government in incorporating eye health services in their national policies. Prior to concluding, I would register my appreciation for the role of the non-governmental organization in eye health services. I thank you all. Thank you.
Thank you, Mr. Secretary. And may I thank Bangladesh for your critical role in leading negotiations for the UN General Assembly resolution last year. Now may I call upon the Director General of Disease Prevention and Control at the Ministry of Health, Republic of Indonesia, Dr. Maxi Rondonuwu. Apologies if I've mispronounced your name. Director General, you have the floor.
Good morning. Excellencies, distinguished guests, ladies and gentlemen. It is an honor for me to deliver a keynote speech in this high-level breakfast session to discuss universal health coverage and eye care. On this occasion, I would like also to thank the organizer for having me in this important site event, the 75th World Health Assembly. I will take this opportunity to share the experience and effort made by Indonesians in achieving the universal eye health coverage. The prevention and control of visual impairment and blindness have been carried out in Indonesia for more than 7 decades ago. It was started with the prevention control of visual impairment and blindness caused by infectious disease and vitamin A deficiency. The commitment of the government of Indonesia to preventing and controlling visual impairment and blindness have been even stronger from time to time. In 1967, the Minister of Health declared blindness a national disaster because the prevalence of blindness was 1% of the total population of Indonesia, which was 105 million at that time. This declaration has led to the intensification of promotive and preventive and curative rehabilitative effort to deal with visual impairment and blindness in the country. The efforts were focused on the prevention and control of xerophthalmia, trachoma, cataract, and glaucoma. The government commitment to the prevention and control of visual impairment and blindness has also been strengthened by the promulgation of the 2009 health law. This law stipulates that the prevention and control of visual impairment and blindness should include promotive, preventive, curative, rehabilitative effort. In the year 2000, the President of Indonesia declared to achieve Vision 2020, where all Indonesian people will have the right to an optimal vision. To achieve this Vision 2020, priority were given to avoidable visual impairment and blindness, such as cataract, refractive error, glaucoma, retinopathy diabeticum, and childhood blindness. The declaration was followed up by the issuance of the regulation of the Minister of Health number 82 of 2020 concerning the prevention and control of visual impairment and hearing loss. The effort include early detection program for visual impairment. These have been started from the smallest group of community, namely the family. The community are empowered to be able to detect visual impairment independently using continuing finger method from the distance of 6 meters. The method was created by the Indonesian Ophthalmologists Association. Additionally, to expand the coverage and to improve the community access towards the prevention and control of visual impairment and blindness, services are provided in community-based health effort, including the integrated non-communicable disease post, we call Posbindu, integrated service post, we call Posyandu, school health program, and occupational health program. These efforts have also been strengthened in involving multi-sector and the community, including health professional organizations. These activities are also parts of the efforts to achieve the global target of eye health of 2030. During 2020 to 2021, the number of people have been covered by the early detection of visual impairment was around 67 and 90, 60, 100. To further improve the community access to quality and comprehensive eye care, the government of Indonesia has established the Vision Center. The Vision Center is located at the community health center we call Puskesmas, and we have around 12,000 health center, community health center in Indonesia. Yeah, and at present there are 5 Vision Center located in province of West Nusa Tenggara. More Vision Center will be established, and it is planned to be available in all districts, 514 districts in the country. In overcoming the community financial barrier in accessing the service in the Vision Center, the social health insurance scheme, we have BPJS, Social National Assurance, has been applied for Icare. Yeah. The government of Indonesia, finally, the government of Indonesia is now taking further steps to achieve a universal health coverage. Thank you.
Thank you, Director General, for your comments, and also for Indonesia again taking the time to join us at this side event, the second time in just 2 years. So thank you very much for your continued leadership. It's greatly appreciated. And now may I invite to the lectern Ms. Kate Wallace, Assistant Secretary, Multilateral Health Branch, Department of Foreign Affairs and Trade, Australia. Assistant Secretary, the floor is yours.
Thank you, Jennifer. And as a fellow Australian, I would really like to just recognise the amazing work of the Fred Hollows Foundation. It makes us incredibly proud every day. And indeed, because I have the privilege of prescriptive eyewear, I'm going to put it on because we know that that is not yet universally available and something that too often we take for granted. It's a pleasure to be here with you all, and I would like to thank the International Agency for the Prevention of Blindness, the Fred Hollows Foundation, the World Health Organization, and partners for bringing us here together in person today to discuss global efforts towards universal access to eye care and to welcome the launch of the WHO's Guide for Action. It's a pleasure to be following the Senior Secretary of the Ministry for Health for Bangladesh, and of course, the Director General for Health from Indonesia. Australia was very pleased to lead, with our good friends from Indonesia, a resolution on integrated people-centred eye care, including preventable vision, impairment and blindness, in 2020. I thank the Indonesian government for their continued leadership on global eye health. Australia is glad to see that our shared efforts on the eye health resolution is leading to meaningful outcomes, including the development of global targets for the coverage of cataract surgery and refractive error endorsed at last year's World Health Assembly. It's vitally important that we continue to see momentum and collective action on the global eye health agenda in order to address the vast inequalities that exist in the prevalence of vision impairment and blindness. With global rates of preventable vision impairment and blindness anticipated to increase over the coming years, the associated personal and societal burden will continue to escalate. We are all acutely aware that this burden disproportionately impacts low and middle income countries and vulnerable populations such as women, migrants, Indigenous peoples, persons with disabilities and rural communities. The Australian health system is working to improve the eye health of all Australians through prevention, early detection, treatment and rehabilitation. In our region, Australia supports a health system strengthening approach to address all diseases, including those related to eye health. And this approach aligns with our commitment to universal health coverage for all. I'm looking forward to the discussions this morning to hear country perspectives on integrating people-centred eye care approaches and to learn more about the ongoing work of the WHO in this important area of healthcare. Thank you.
Thank you, Kate. And may I extend our immense gratitude to Australia for your long-standing and continued leadership in global eye health. So I think it's clear that progress requires leadership and a will to act, which is a perfect segue to our next item, the launch of the WHO Eye Care and Health Systems Guide for Action. So I would like to invite Dr. Bente Mikkelsen, Director, Non-Communicable Diseases, WHO, to welcome everyone on behalf of the WHO and to also launch the Guide for Action. Thank you.
Thank you so much, Jennifer, and Excellencies, friends. I am sure that you are like me, you really enjoy landmark events, right? So today we have a landmark event. It's even something that I think we can appreciate by listening to the global leadership. So I don't know if Bangladesh, Indonesia, and Australia understand the importance for WHO of having your leadership. And not only at the global level, but we heard today as well fantastic examples that we need to follow from your countries. So, of course, this is not possible without all the other friends, and we have strong friends for Icare, and we need you in the continuation as well, because all hands need to be on deck, even if we have a beautiful guideline. So I want to thank all of you coming here early morning in a beautiful place and with privileges, like you said as well. We also need to acknowledge those who are not in the room, and we had like 400 experts helping us from across the world. And of course, I love WHO, and one of the beauties of WHO, and I want to share that with you, is that we can call on the best experts, and they come. They don't even ask for much, and they are very happy to share their knowledge. So that's how we came to the WHO Icare Guide for Action and related tools. I have a personal feeling for this agenda. It has been my privilege to be able to oversee this in my different positions in WHO, from earlier days in HQ Geneva, but also in the Euro office, and now back in Geneva in this very, I would say, promising times. So within the NCD department, we are very eager to work cross-programmatic, because all of you so far has talked about the integration. And I think that is what we really need to look for when it comes to Icare. So we were very happy also to launch together with the government of Canada last year the Global Diabetes Compact. And this is also important, of course, as you all know, for this program because of the diabetic retinopathy. So the statistics that Alarcos and Stuart will provide you with will be sobering, and it will be a reminder of how much work is still to be done, because this is only the beginning. And of course, I think we all agree it's outrageous that in 2022 we had 1 billion people with vision impairment, and we have the oldest program in WHO starting at 1970. And it's not even big innovations needed. So I'm extremely eager to see the SPECT initiative come true. Jennifer already mentioned the two or several, actually, World Health Assembly and UNGA resolutions, so I won't tire you with that. But I will tell you that we are committed. We are committed to support the member states. We need to support the member states for the implementation of the guide, even if we have the guide, and you all know that. We need to strengthen the data and use this as a pathfinder also to achieve universal health coverage and the SDGs to come with them. And we also need true continued collaboration, and I hope really that we are all on board on that, to develop the SPECT initiative. We cannot do this alone, none of us. So on behalf of WHO, I would like to welcome you again, and I look forward to the discussion. So again, we can have a look, and now we are going into the details. Thank you very much, Jennifer.
Yes, as Benti said, now we're going into the details. So on that note, I would like to invite Dr. Stuart Keel, Technical Officer for the Vision and Eye Care Program, to take us through the key elements of the Guide for Action. Over to you, Stuart.
Thank you very much, Jennifer. So I'm very, very happy today to present on behalf of the Vision and Eye Care team and all of the work that has happened in the program over the course of the last couple of years. So the first thing I wanted to do is just reiterate and echo Bente's sentiment earlier, and just really thank all of the public health, clinical and academic experts from the field of eye care that contributed. We have a graphic display here of the distribution across the world of all of these experts, and of course without your time and effort, I know many of you are in the room but also online, none of this would have been possible, so thank you very much. So over the course of the next 10 to 15 minutes, I want to cover 4 key topics. I won't spend much time on the first 2 because we've been through those a bit this morning. But one of them is just a recap on what are the key challenges facing the eye care sector. The second is to look at those high-level UN documents and decisions that have helped shape where we are today in terms of the Icare agenda. And then, of course, the reason why we're here is to have a look at the Icare Guide for Action and the related tools that we launched today. And then I'll spend a few moments just going through what are the key priorities from a WHO perspective moving forward. So we heard this before, but one of the key challenges, and starting with one of the primary challenges, is simply the huge need and unmet need for eye care. And we know that at least 2.2 billion people globally have a near or distance vision impairment, and of these, at least 1 billion have a vision impairment that could have been prevented or is still to be addressed. And if we have a look at the breakdown of the major causes of vision impairment, we can see that the vast majority of these cases can be addressed through very cost-effective interventions in a form of a cataract surgery or also a pair of spectacles. And then we have other causes such as glaucoma, diabetic retinopathy, in which very effective interventions are available to prevent vision impairment. But this 1 billion people really just touches the surface and is really the tip of the iceberg when it comes to the need for eye care services globally. And that brings me to the second challenge, which is eye conditions are universal. And everyone, if they live long enough, will experience an eye condition in their lifetime that requires the appropriate treatment. And we just have to look at the sheer numbers of people with eye conditions that can cause vision impairment to demonstrate this, where we have already over 2 billion people with myopia who need glasses, or short-sightedness who need glasses. We have close to 2 billion people with near vision impairment due to presbyopia that can be corrected with a very simple pair of reading glasses. And then we have over 400 million people with non-communicable eye diseases, including glaucoma, diabetic retinopathy, and also macular degeneration. But the importance of eye conditions that don't typically cause vision impairment shouldn't be understated, because these eye conditions are the most frequent reasons for people seeking care in a large number of countries. And for these reasons can pose financial and individual hardships due to the treatment needs associated with them. To confound all of this huge need is the fact that it's estimated that many of these eye conditions will increase substantially in the coming decades due to ageing populations, population growth, but also lifestyle factors when we think about diabetic retinopathy and myopia. Finally, the challenge that I wanted to mention that directly relates to our Guide for Action and related tools today is really a lack of integration of eye care within the health system. So we know that even very basic eye care interventions and medicines are often not included within health insurance schemes in low and middle income countries. And then, of course, cost is a major barrier to accessing services. The reality is that the vast majority of services are provided at secondary and tertiary level hospitals, and mainly in urban centres in low and middle income countries, which really adds to the inequities. At times, there's an uncoordinated and unregulated workforce that can lead to inefficiencies, parallel services and suboptimal outcomes. And we know that even in countries with very developed health information systems, they often don't include data on eye conditions, vision impairment and their determinants, and therefore health planners often lack the information they need to allocate resources appropriately. So it's clear from all of these challenges that I have mentioned that, and just the sheer need and projected need for eye care, that new strategies are required. And in fact, there's a very strong health economic rationale to increasing the coverage of eye care interventions. And it's estimated that the global cost to address the coverage gap of vision impairment, which is that 1 billion figure that we saw before, is about $25 billion US. So this may seem like a very large figure. However, when taken into consideration, is only a very small fraction of the estimated annual global productivity losses of vision impairment, which is in excess estimated to be over $410 billion. So there have been a number of documents and decisions at the UN level that have helped shape the new eye care agenda and where we are today in launching the Eye Care Guide for Action. Briefly, this started in October 2019 with the launch of the World Report on Vision that set out a number of recommendations to address some of these key challenges that I mentioned before, including making eye care an integral part of universal health coverage and also implementing integrated people-centred eye care. The recommendations of the World Report on Vision were then endorsed by member states with the adoption of an Icare resolution in 2020 that we've heard about before. Following this, at the subsequent 74th World Health Assembly, 2 new global Icare targets were endorsed for 2030 that relate to the 2 leading causes of vision impairment, and namely a 30% increase in effective coverage of cataract surgery and a 40% increase in effective coverage of refractive error. And finally, but certainly not least, the very first UN General Assembly resolution on Icare was adopted by member states last year, and really highlighting the fact that improving eye health and preventing vision impairment can directly contribute to sustainable development goals beyond those related to health, including improving education, improving productivity, and also equity, amongst others. So WHO's work is guided by this World Health Assembly resolution from 2020, and this resolution urges member states to implement integrated people-centred eye care and requests WHO or the Director General to complete a number of activities, including to provide technical support to countries to implement the recommendations of the World Report on Vision. So with that request, WHO is very pleased today to launch the Icare in Health Systems Guide for Action, and really with the purpose of providing a practical, step-by-step guidance for health planners to implement integrated people-centred eye care on the ground. And it does this by linking a series of evidence-based technical products or tools to help support country planning. So I'll spend the next few minutes going through and unpacking the Guide for Action. And really the Guide for Action is an umbrella resource, and you'll see as you walked in the door and also on our webpage that there are a number of other tools that we're also launching today. So the Guide for Action provides this umbrella resources, but is accompanied by 4 different technical products to support countries through a phased process. And this starts with situation analysis, in which we have the Icare situation analysis tool available to support. This is followed by the development of a strategic plan and also a monitoring framework for Icare, in which we're very happy to launch the Icare indicator menu today to support. The third phase is the development and implementation of an operational plan for Icare, in which we're very happy to launch the package of Icare interventions today, and also the Icare competency framework to support workforce development. And lastly is establishing an ongoing monitoring and review process, in which there's practical guidance included within the Guide for Action. So let's have a look at each of these tools in a little detail now. So the first tool, starting with the situation analysis tool, is the EXAT. And this isn't an entirely new tool, but has recently undergone significant revisions to be in line with the strategic recommendations of the World Report on Vision. And what the purpose of this tool is to provide a questionnaire-based tool to comprehensively assess eye care in a country, including what are the strengths, weaknesses, inequalities, but it also sets out a number of possible activities to address the gaps that have been identified. So this tool is ready and available for use today, and also to say that it's currently being digitised to enable even easier data entry and evaluation of the outcomes. The second tool accompanying tool that we launched today is the Icare Indicators menu. And this Icare Indicators menu provides a comprehensive set of indicators from input, output, outcome and impact indicators to facilitate countries in monitoring strategies and actions for eye care service provision, both at the national level and or at the subnational level. And of course, the indicators that are linked to the 2 global targets of effective coverage of refractive error and effective coverage of cataract surgery are included within this indicator menu. Also to note that the facility level indicators that are included within this menu are currently being included within the district health information software into a package that is currently used in over 70 countries and will be available and ready for use later in 2022. The third tool that we launched today is the package of eye care interventions. And really this package contains 2 key components. Firstly, it has recommended evidence-based interventions along the continuum of care from health promotion through to vision rehabilitation. Also across the different levels of the health system, from community through to tertiary levels. But then it includes the material resources required for implementing these interventions, including the equipment, medicines, consumables and assistive technologies. So this package has been integrated within the UHC Compendium of Interventions, which is a broader tool at WHO that includes interventions from all health program areas. And really, it's the intention that using these resources and evidence-based resources, of course, along with reliable local data, that it really will facilitate health planners on which Icare interventions to prioritise, how they can be budgeted and also integrated within health systems and health services packages and policies. And the final tool that we launched today is the Icare Competency Framework. And we mentioned before some of the sheer need for Icare services and some of the workforce challenges. And in order to meet these population Icare needs, a competency-based approach is particularly required in low and middle income countries. So this Icare Competency Framework conveys the expected performance of an Icare worker across the different levels of the health system to ensure the provision of quality Icare. And it's been developed to really support planning and development of the workforce, aligned with standards of competencies and activities in order to meet this huge population Icare needs. So important to note here that this global tool will soon be accompanied by guides to really help contextualisation and implementation at the country level. So of course, I've only been able to touch the surface on these tools that we launched today. I encourage you all to go to the WHO webpage and download the documents. I also to let you know that all of these documents will be translated into the WHO official languages, will be available on the webpage in the languages over the course of the next months. So I want to finish by talking about what are the key priorities and areas of work moving forward from a WHO perspective in the context of Icare. And of course, using the tools that we launched today, we are committed to continue to support member states in implementing the World Health Assembly resolution on Icare, on integrated people-centred Icare. Another area that has been mentioned is we're also very committed to strengthen data to monitor progress towards the 2030 targets on effective coverage of cataract surgery and effective coverage of refractive error. In the short term, this will involve working with our partners and academics in the field to formulate baseline estimates that we hope to launch later this year. And secondly, really playing more of a coordinating role with key stakeholders in the field to collect reliable data moving forward. And lastly, and as Bente mentioned before, just given the huge unmet need for care in terms of spectacles and refractive error, WHO has recently launched the SPECS initiative, really with the objective to work with key stakeholders in the field to develop the appropriate technical guidance, but also work to support with these partners to help member states increase spectacle coverage in a sustainable manner. So with that, again, thank you for your time and attention, and back over to you, Jennifer.
Thank you, Stuart. It's obvious how invaluable these tools will be to guiding governments and actors from across the sectors, all sectors really, to move from commitments to action on the ground. But of course, work has already begun in many countries to commence implementing the strategies of integrated people-centred Icare, or Ipec, as it's commonly referred to. So let me introduce our esteemed panel to share some reflections and experiences to date in implementing Ipec. So joining us online, we have Dr. Bernadetta Shilio, Program Manager of the National Icare Program, Ministry of Health in Tanzania. And then joining me on stage will be Dr. Hewitt Solomon, Director of Disease Prevention and Control with the Federal Ministry of Health, Ethiopia. Dr. Alako Sieza, who heads up the WHO Unit for Sensory Functions, Disability and Rehabilitation. And Mr. Brandon Artong, Head of Public Policy and Advocacy with the Fred Hollows Foundation. And Mr. Peter Holland, CEO of the International Agency for the Prevention of Blindness. Now I'll just come and join you over there. Okay, so welcome to the panel. If I could start, please, with you, Dr. Hewitt. Could you please share with us your experiences in initiating Ipec at the national level in Ethiopia?
Good afternoon. Thank you so much for having me, and it's also a very good experience for us to share about the Ipec implementation in Ethiopia. The very start is we adopt as a country after the 73 World Health Assembly resolution, that's guidance given by WHO. Eye problem is one of a major public health problem in Ethiopia. We do have millions with blindness suffering and also impaired eye vision problem. So integrated eye care program is very ideal for the country to work on and help our community. Without wasting time, the country Ministry of Health, especially our partner, Tedras Foundation works together with us and adopt the WHO guidance, the Ipec guidance. So we call all Icare partners in country and also have multiple consultative workshop to have a good understanding about the program. So after that, we recruit technical assistants because it is very easy to have a good coordination and directly go to the ground to get evidence regarding with the WHO guidance ICAS tool to start assessment of our situation. So after having that, we call another workshop to disseminate the findings and have a good discussion multiple times, and after we finalize our report accordingly. So these are the steps, the major steps, what we use. Thank you.
Thank you, Dr. Great example of implementing Ipec, indeed. Now, do we have Dr. Bernadetta online? Oh, hello. I've got bottles in front of me. I can't see on screen, but welcome. If I could ask you a question, one of the key strategies of Ipec is to reorient services towards primary and community care. How has the Ipec approach helped improve access to primary eye care services in Tanzania?
Thank you. Tanzania is one of the East African countries where Mount Kilimanjaro is located, and we have a projected population of 64 million, 26 administrative regions, and over 8,500 health facilities. And at these facilities, health workers do not have a knowledge on eye health. And we realize that it's a missed opportunity to reach them. And integrated people-centered eye care was the way to go. And we use the WHO primary eye care guideline, which was launched a couple of years ago. We customized it to based on the country situation. And we produced it by training the trainers and also the national trainers, master trainers and national trainers. And we rolled it out to 3 regions. And in these regions, we trained a total of 525 health workers from 505 health facilities. Further to this training, we also introduced the Ipec app with the mobile phones in one of the regions. And with the 6-month experiences, we realized that access to eye health has increased, an overall of 10% in the country, but for the targeted regions, we had an increase of 30%. Apart from an increase in the number of people who were reached, we also increased the number of people who were referred and reached the secondary or the specialized health units. And this increased to a fold of 23%. So we envisage that the positive impact of embedding primary eye care in the primary health facilities is the way to go, and we appreciate for the successes which we have achieved so far.
Thank you, Dr. Bernadetta. That's great progress so far. Terrific. Brandon, if I could ask you a question. Ipec emphasises the need to strengthen health systems to ensure people have access to quality care across the spectrum of services, from health promotion, prevention, treatment and rehabilitation. How do you see this Ipec agenda supporting people living with unavoidable blindness and vision impairment?
Thanks, Jennifer. And I'm here also, representing as a member of Blind Citizens Australia, a
My
consumer
apologies,
body.
I should have mentioned that when I
No,
introduced you.
no problem. So I think for me it's really about how it feels in interacting with the health system. And for me, it was quite a complex situation. And I have a condition called retinitis pigmentosa, which is a condition that goes down over time. So over about a 10-year period, I went from being able to drive and play rugby, and eventually I wasn't able to see my own hand in front of my own face. So, the experience of blindness is obviously unique, and there is no one experience. It can often be determined by where you live, where you're born, your social, your economic status, your gender can determine your experience. It's common to sort of think of it in terms of someone may interact with a screening service where a condition may be detected. There'll be some onward referral through to a specialist for diagnosis and perhaps some treatment. Then being referred through to, say, vision rehabilitation services where someone might get skills, training around mobility or literacy using perhaps Braille or adaptive technology. And even perhaps onward referral through to peer support to learn how to interact in a world which is largely designed for people with sight. So that's the narrative, but of course the experience is often quite different and can feel quite fragmented. We know that often those different parts of that journey just don't exist in different settings where people are. We know that often the different parts of that journey don't speak very well to each other and may not understand how they can support each other. So the feeling of fragmentation is quite palatable for some people. Now, I think the beauty of Ipec is that by design, it seeks to turn that on its head and to break down those silos and to put people at the centre. Now, by design, it intentionally looks to identify what the gaps are, to plan how to fill them, and then going about actually doing it to make sure that there's actual change. So, in a nutshell, I think having implemented Ipec, my hope is that the feeling of the experience is one of more seamless and integrated care. That's probably the best way to put it.
Yeah, really well said, Brandon. I think you sort of hit the nail on the head when you say putting people at the centre is what this is all about, and it does make services become a different focus than previously. Peter, as the international umbrella body for iHealth representing the broad civil society sector, what role do you see your members playing in advancing universal health coverage and the Ipec agenda?
Well, Jennifer, thank you. So just briefly to explain for those who don't know IAPB, as you say, we're the global umbrella body for the Icare sector. We're a membership organisation. We've got over 180 members worldwide, based in more than 100 countries, drawn from non-governmental organisations, private and corporate sector, eye hospitals, academic institutions, and the professional bodies. So we really are a global organisation, and we've worked in partnership with World Health Organization for decades, and it's been a great relationship. And I guess the first area I'd point to is around the sorts of technical support, expertise, and capacity building that our members bring, and we've already heard examples of that. Many of the 360 odd experts who worked with Stuart and the team in terms of developing the guide for action come from our members. Dr. Solomon, you talked about the work that you're doing on the ground with our members. So there's the practical support that our members are providing around the world. The second area I'd point to would be around partnerships. This event is a great example of that partnership that we have with World Health Organization. But those partnerships go much wider. So there's the partnerships that we have at the global level, but actually we can help bring partnerships, particularly, I think, between the non-governmental sector and the private and corporate sector. And there are great examples, for example, in tackling trachoma, where we've already seen that happen. And both Dr. Mickelson and Stuart, you were mentioning the SPECS initiative. We won't achieve our goals around refractive error and making sure that everybody have access to glasses without working very closely with the private and corporate sector to do that. And I guess the third area I'd point to is the work we do on advocacy. We work at a global level, obviously here in the World Health Organization at the UN, in terms of trying to raise the profile of eye health. But importantly, we need to do that at a country level as well. I guess holding government's feet to the fire a bit in terms of actually implementing your commitments, but also looking outside the eye care sector. And Stuart, you mentioned the impact on productivity. Eye health isn't just an issue for the healthcare system, it's actually something that cuts across all of government. So actually raising the issue across all of government and trying to get the focus and the resources that we'll need and need to implement Ipec. So I think all those range of areas, members will have a role.
Yeah, it's going to be a busy time ahead, Peter. And Alakos, in terms of the guide for action, what would you say would be the 3 key messages for ministries and others thinking about how to engage with implementing or the IPEC agenda?
Yeah, thank you, Jennifer. Let me first of all say how, on the one hand, humble I feel today to be here at this launch event of the Guide for Action. And actually humble because it really has been a huge effort over 3 years, and humble because we have had all these people, the whole sector, 400 people really contributed with their time, their expertise, and really their commitment and passion to move this forward and to do this. And at the same time, I feel proud to be here in front of you all today and with a great team also making this happen. So first of all that, and thank you again. I also feel humble based on what Brandon said, and he put really the things, he mentioned really the core of what this is about, and you, Jennifer, emphasized it, is really putting people at the center and really having the vision that it is possible really to have integrated people-centered eye care with people at the center. So now in terms of the 3 messages, and I have actually 3 words so that really you policymakers can really keep in your mind. So the first one is responsibility. The second one is readiness. And the third one is report. So you have 3 R's, yes. Easy to remember. So responsibility. Actually, my point is, it is your responsibility, ministries of health and in the health sector, to move this agenda forward. It is you cannot let it move alone by the private sector, by civil society and NGOs. It can be done in collaboration with the private sector and with NGOs, but it cannot be done only by them. It needs your leadership, your responsibility and coordination. And then it can happen. Then we will have the people experience that Brandon was talking about. So please take this responsibility. It will not happen otherwise. We will be sitting here 20 years from now, still talking about the same challenges. The second one is readiness. And look, the field is ready for you. You see here the people needing those services, telling you, please move forward. We need those services. You have the NGO sector telling you, we are ready to support. We still have to work hard on the private sector, one need to admit that, so that they also move along. But we are ready here to really also work with the private sector to make this happen. And in theory and in principle, you also have the political commitment. You know, we have 5 resolutions in Icare in the World Health Assembly. We have a UN resolution, and the question is what you are waiting for to really, again, take this responsibility. So the field is ready, take the responsibility. And the third one is a report. You know, again, we could sit here in 20 years and say, okay, what has happened? What have we done? What have we achieved? And not knowing that. So it is also your responsibility to really integrate the indicators that are appropriate, that are tailored to your countries, to your actions, to the actions that we have heard today, that you are moving in your countries, with the indicators that has been really developed in a scientific and also with the knowledge and expertise of the field to integrate in the health information system to make it happen. It is a lot at stake because also in terms of reporting, because we have now the potential of having 2 Icare indicators, effective coverage of refractive errors and effective coverage of cataract surgery, included in the SDG monitoring system. And if we don't move, it will not happen. And I tell you why it is important to have these two indicators, and then, of course, another service indicators, but especially these 2 indicators. Why they are fundamental? Because actually we are talking about basic interventions, really basic. Actually, one can even wonder if a health system let people going blind or the child's not being able to attend education because of the lack of a pair of classes. How bad needs to be the health sector in terms of moving towards universal health coverage. So these are 2 indicators that are very sensitive to the progress that you, ministries of health, are doing. So, but we need to really commit also to collect that data, because with that data, you would also be able to demonstrate and be proud that you are making it possible and making it happen. And also, again, you are moving your health sector and the universal health coverage, putting people at the center. So I stop there. So again, responsibility, readiness, and please report.
Thanks, Alakos. As always, an inspiring call to action, and I just love your 3 R's. So easy to remember. Absolutely fantastic. Okay, I'd like to now move to the Q&A session and start to bring some of you into the discussion. And because this is a hybrid event, I'd like to sort of bring the online people into the room, so to speak. So Debs, you've got a few questions, I believe, from online. Yes. Over to you.
Thank you, Jennifer, and thank you to our online speakers as well for your questions. So we've got our first question is from Richard Hughes from Fred Hollows Foundation, and it's for Dr. Solomon. I could read out the first 2 questions so you can have a chance to have a little listen. So Ethiopia has clearly had great success initiating Ipec. What steps are you planning to take next? Okay, so I'll leave that with you for a second. And then we've got another question to Dr. Shilio. You've had remarkable progress in Tanzania at the primary care level. What steps are you taking to ensure continuity of care across different levels of the health system? And that comes from Jude Stern at the IAPB. Thank you.
Thank you so much. It's also a very important question because doing assessment and initiating this very nice initiative is not enough. So the next step is very critical. So as a country, Ministry of Health is coordinating the whole effort together with its partner and relevant stakeholders. So the next step is we already have a good information regarding the situation in Ethiopia. We do have that in terms of public facility, which providing Icare service, and also at the policy makers level, starting from the federal and also implementing partners. So we know the situation. So we have pros and cons of all this exercise, the ground available resource for Icare care service implementation. So the issue of Icare is not only the health problem, it's beyond. It has a connection with the economy, social, and other factors. So the plan is to engage all multi-sectoral efforts together with the involvement of the Federal Ministry of Health and other line ministries. So this is a major action will be, and it's already started in somehow. We involved the private health facility and NGOs and others. So we already have a good line of responsibility. So in this case, the next action will be to go for data sharing, collaborative work, joint planning, and also reporting of all generated information, and plan to integrate it to the health system, reporting system. That's the main plan. By doing that, definitely we will have a good eye for the implementation and to monitor and evaluate the actual implementation. So this is our next action will be. Thank you.
Excellent. Yeah, you really are leading the way in this implementing Ipec. Excellent. And over to you, Dr. Benedetta. Can she hear me, Dr. Oh.
Hello, thank you so much. Thank you. Yeah, we in Tanzania, as we have said, the achievements which we have observed so far through the primary eye care, but we have realized the primary eye care by itself is not sufficient to ensure the continuum of care. So for Ipec to be implemented, we have to address all the WHO building blocks to ensure that there's good governance, the human resource, the infrastructure and equipment across all the levels, so that we may ensure that there is continuity of care. And we have plan of having it in a comprehensive, to upscale the primary care, but in a comprehensive way, and to be able to make people aware of the need of themselves to take care of their eye health. And we will focus more on the promotive, the preventive, the curative, and rehabilitation. And we cannot do it by ourselves. We need collaborative efforts to ensure that we'll be able to employ the innovations such as simple and affordable technologies to help doing the screening and the early referrals. So we invite partners who will join hands with the government to ensure that we realize our goals. And with this, I would like to thank all the partners who are joining hands with us. In particular, we have site savers and the CBM who have worked with us to ensure that we have been able to implement the primary eye care in Tanzania.
Thank you, Dr. Benedetta. Yes, working in partnership is definitely going to be key to successful implementation of Ipec. Now we might move into the room to see if anyone here has a question. We have a roving mic, so yeah, we've got a couple of hands.
Thank you for this engaging discussion. We know that the social determinants of health, and looking at those, that it's very important to engage with colleagues outside of the health sector, and certainly this has been touched on by Peter and Hirut, but I was wondering if you could please expand on what efforts are being undertaken to work with colleagues outside of health to address the underlying causes of these health issues.
Peter, I think that might be a good question for you, particularly given the UN resolution and the Sustainable Development Goals. So can I hand over to you? And of course, if anyone else on the panel would like to add, we can move to that.
Sure. Well, I mean, we've heard actually a lot of examples already of exactly what you describe about the impact that Icare has on a much broader range, particularly of the Sustainable Development Goals, than simply universal health coverage and the healthcare areas. And obviously that was recognised last year in the UN resolution, which was the first UN resolution on vision. Really, it's the first time it's actually been discussed at the United Nations. And I'm going to take this opportunity particularly to thank Bangladesh, Ireland and Antigua and Barbuda, who led that agreement of the resolution. But that drew out, crucially, those links. And I think firstly, I would point to what Dr. Solomon said, that the answer to this is that Icare, because it goes so much broader, needs a cross-government approach, and the kinds of cross-government approaches that Dr. Solomon described. There are any number of practical examples, particularly, for example, in school eye health, in terms of developing eye care programs in schools to reach children, because we know in lower and middle income countries that children who have sight loss are something like between 2 and 5 times less likely to be in school. So actually reaching children to ensure that they have access to the eye care they need is really going to be absolutely critical to their education outcomes. I think working with businesses is crucial. Again, the evidence, Stuart quoted the global figures on productivity. Those are almost certainly a huge underestimate. They were published in the Lancet Global Commission. They said they were a very conservative estimate. And at a business level, we know that providing access to glasses and eye care services can improve productivity between 10 and 30%. And there are some examples of businesses really providing eye care to their employees. But I think that's an area where actually there could be there's scope for enormous growth and working. And I think that's particularly where there can be partnerships between NGOs, businesses, and indeed governments to do that. So I think there are a whole range of practical interventions that you could look at.
Thanks, Peter. I see a couple of hands. We're going to be. I was remiss. Could you please say who you are and where you're from before you ask your question, so that we know?
My name is Ivo Kotsura. I'm from the International Council of Ophthalmology. And of course, congratulations on this launch. And I would like to also bring Professor Neru Gupta, our president, representing the organization. So Alarcos and the team and our IAPB colleagues and friends, congratulations. ICO have contributed through our experts. Now the question. Alarcos, thank you for the 3 R's. They are amazing and really stimulating. It would be good maybe also to remind us of the reporting mechanisms for the resolutions, because as you said, reporting stimulates action and it's good to get ready. So what is the mechanism now? When can we actually expect the reports to be presented at the WHA again? And what typically happens when the reports are given? Next resolution is probably to be prepared. A little bit about that would be very helpful and stimulating. Thank you.
No, thank you. Thank you, Ivo, and thank you also for the collaboration indeed of the International Council of Ophthalmology. And look, there will be, actually, I have to admit, I would need to check when we will have to report back to the World Health Assembly, but it will be in 2 years' time. We collect information through our mechanisms of our country's office, Ministries of Health. We collect information from countries of the activities that has been done. In addition to that, what WHO is also developing and doing is a mechanism so that we can coordinate and collect data through other platforms to make sure that we can also report on especially also on the 2 global indicators for effective coverage of refractive errors and effective coverage of cataract surgery. We are in process of developing that mechanism, selecting also what are the countries where it is feasible, also making sure that funds are available to support countries to collect this data. And the sector stakeholders, Ministries of Health, will hear also from us over the next months in this direction to move this agenda forward, data collection. Thank you.
Now, I know that there's a number of hands still here, but we are really running out of time here, and I would like to encourage everyone to stay post this. The panel members will be here for a few minutes, and we're happy to answer more questions, but I think it's with these hybrid events, you have to kind of stick to time. So I really do need to, there's a couple more things we just need to close off before we finish. So I did want to just give a final word. Actually, I had a quick question for you, Brandon, just before we give a final word to Alakis. If there was one message that you'd like to share in listening to the discussion that you've heard, so far, from the perspective of someone with lived experience of blindness, what would that be in maybe 10 seconds?
People are complicated. We don't fit neatly into boxes, and I think Ipec can show us the way, but we've got to take steps ourselves and act to bring it alive. So I think that's probably, is that 10 seconds?
I think that's pretty good. And finally, Alakis, maybe again in just 10 seconds, if there was anything that you want to add to all the responses you've heard today, what would it be? But probably importantly, where should people go if they want to have any questions or, find out more about what to do?
Yeah, okay. If you want to find out what to do, I think the best way, Stuart, is to provide your email and contact Stuart from the team, who is leading, and we will be able then to distribute the questions among the team members and come back to you. But look, I would like to emphasize 3 things that have been mentioned, but I think it is important also to emphasize the why it is important to move this agenda. And I think one of them, it is the impact, because when we talk about other sectors, other areas, other SDGs, is really the impact that making people's life better through Icare really have in all areas of life, in all other, at global level, also SDGs. So that is one reason. Another reason that was also emphasized by Kate Wallis from Australia is equity. It's a question of equity, and equitable access to services, and that is an injustice. Actually, when we talk about equity, it's about an injustice that there are people that do not have access to quality, basic interventions. And it is a question. It is also a why. It is a return on investment. So we were talking about over 400 billion lost productivity. And again, the final why, we are ready. So it is responsibility, readiness, and don't forget to monitor the progress.
Thank you, Alakis. Okay, so before closing, it is my pleasure to introduce the Director General of the World Health Organization, Dr. Tedras, who has kindly recorded a message for us all to hear. So if we could roll the videotape, so that's right.
Excellencies, dear colleagues and friends, over 2 billion people globally live with a vision impairment. At least half of these cases are impairments that could have been prevented or are yet to be addressed. This burden is not borne equally. 90% of people with vision impairment or blindness live in low-income and middle-income countries. Often, the greatest needs fall among people living in rural areas, those with low incomes, women, people with disabilities, ethnic minorities, and indigenous populations. Integrated, people-centered Icare has the potential to improve millions of lives worldwide. Often, all that's needed is a cost-effective intervention, such as a pair of spectacles or cataract surgery. I'm encouraged to see member states acting on their global commitments to include eye health in their national health programs. This is an important part of every country's journey towards universal health coverage. WHO will continue to support these efforts with our new Icare Guide for Action, while also working together to gather better data that will help accelerate progress. We're grateful to all our partners for your ongoing collaboration as we strive for a world where every person has the opportunity to see clearly. I thank you.
Well, thanks, everyone. So that brings us to an end of our program. I would like to thank our distinguished speakers from Bangladesh, Indonesia and Australia, the WHO and all of our panel members. Thank you very much for joining us. I'd also like to thank the co-organisers, the IAPB, CBM, Light for the World, Sight Savers International and the Fred Hollows Foundation. And thanks also to NYT and the Fairmont Hotel for hosting us here today. I think if action was the theme of today's story, working together would surely be the backdrop. We all need to find our own role and work together to ensure that everyone everywhere has access to quality eye health services, with Ipec guiding the way. So wherever you may be in the world, whatever time it is, morning, noon, afternoon, evening, thank you for joining us today, and goodbye.